Hi, everyone, and welcome back to our next episode of ReWalk's Topics in NeuroRehabilitation webcast. I'm Kathleen O'Donnell, and today we'll be talking with FES Cycling expert Judy Meier. Judy is a physical therapist with over 32 years of experience and an extensive background in multiple clinic settings, including acute care, outpatient, skilled nursing, and director of rehab and home health. Throughout her career, Judy's experience has had an emphasis in neurological rehab across the full continuum of care. After leaving clinical practice, Judy has spent the last 8 years working with medical device companies, including Bioness and RTI, to help expand the knowledge and usage of FES technologies for neurorehabilitation. Judy is currently the clinical specialist for MYOLYN and uses her extensive knowledge to help educate clinicians on the benefits of FES cycling for neuropopulations. Her talk today will introduce many of the considerations and clinical benefits of FES cycling and provides examples of how clinicians can utilize this technology to help improve functional outcomes and quality of life for patients with a variety of neurological diagnoses. Hi, Judy. It's great to talk with you today.
Hi, Kathleen. Thank you for having me. I appreciate the opportunity to discuss FES cycling in the clinic as well as for home use for patients.
Absolutely. And, Judy, I'm really excited to hear your talk today because, as you know, ReWalk and MYOLYN recently entered into a partnership to help introduce Myocycle technology to commercial clinics and VA facilities and veterans throughout the U.S. And I'm really excited about this partnership because FES cycling has so much potential to really promote neuroplasticity and really improve health outcomes in neurorehabilitation. So I'm really looking forward to hearing about your experience and how clinicians can utilize this in the variety of settings to help maximize these outcomes. And to our viewers, we'd love to hear from you as well. So if you currently use FES cycling in any of your neurorehabilitation programs, or if you prescribe FES cycles for home use, tell us some of your recommendations for how you use this technology to get the best outcomes. So we'd love to hear your thoughts, and don't forget to like and subscribe to this video if you want to hear more talks like this one. So with that, Judy, I'm going to let you take things from here.
Okay, great, Kathleen. Thank you. Like Kathleen said, I've been using FES technology in general for over 8 years. I've been specifically working with FES cycling with upper extremity and lower extremity, as well as core, for the last 6.5 years. So I'm just going to introduce you to some of the benefits and history of it, and go through some of the clinical benefits and the actual applications for home use. So what is FES cycling in general? So it's a therapeutic activity. It involves the application of using functional electrical stimulation to muscles in a rider's limbs to either assist or induce cycling. The components in an FES system are a motorized ergometer that can provide either the assistance needed to propel their legs or resistance to actually give them progressive resistive exercise. There's also a stimulator, which is where the stimulation is being derived from and being applied through leads and electrodes to the appropriate muscle groups. And then there's also a position sensor, which lets the stimulator know where the limbs are, so it knows when to stimulate the muscles throughout the pattern in the revolution to get the peak muscle force. So who benefits from FES cycling? So all the published research on FES cycling has been performed with patients, specifically initially started with SCI patients, and then realizing we're trying to drive neuroplasticity, it can be used for a multitude of neurological disorders. Anyone with an upper motor neuron lesion can benefit from FES cycling, which would be multiple sclerosis, stroke, brain injury, cerebral palsy. Transverse myelitis is also another common usage for that. FES cycling is performed by anyone who cannot independently or volitionally use a cycle of their own due to a neuromuscular impairment, assuming they have no true contraindications. So contraindications to STIM might be certain musculoskeletal conditions, also potentially some implanted electronics. Again, like any modality, you would always want to get doctor's clearance prior to utilizing it if you have any questions. So in general, you're wanting to use it on patients that have their peripheral nerves are innervated. If they have denervation, that could also be an issue as to developing the greatest response, which is what we're trying to do by producing motor activity and muscle activity. It is not contraindicated, but you want to make sure in general patients' peripheral nerves are innervated in order to use FES cycling. Why do it? Because it's exercise. FES cycling allows those patients with impairment to achieve resistive exercise. The 4 main FDA cleared indications for FES cycling are relaxation of muscle spasms, prevention and retardation of further disuse atrophy, increasing local blood circulation, maintaining or increasing range of motion. There is a 5th indication, which is muscle re-education, which came into play as we started to work with those patients that are more hemiparetic or do still have some volitional movement. So muscle re-education is something that is also derived by using any form of FES on a patient. So neuromuscular impairment in general leads to decreased physical activity. And then that leads these patients into having more secondary conditions and complications like atrophy, spasticity, decreased bone density, decreased cardiovascular fitness, leads them open to pressure sores, obesity, heart disease, diabetes, stroke, depression, and overall decreased quality of life. Why do it? FES cycling enables patients to perform activity they cannot complete on their own volitionally. At 35 RPMs, which is the general speed for leg cycling, you can achieve 350 repetitions of actual muscle activity in just a 10-minute session. So FES can be applied to affected muscles throughout the body, in the lower legs, thigh, core, and upper body. FES cycling enables functional activity to help improve their overall functional outcomes. We're going to talk a little bit more today about the actual Myocycle, which is produced by MYOLYN. The Myocycle itself uses FES technology plus isokinetic cycling, which equals mass practice functional activity, which should be a standard of care used throughout all rehab programs. When to do it? Well, all the research shows that basically using FES in general, and especially FES cycling, the earlier the intervention and the more frequently you use it, the better the overall outcomes are. So FES cycling has been around since the 1980s, and there's been various forms of FES cycling that have been used, and it just continues to improve the technology. It's a therapeutic intervention after any kind of neurological injury, typically performed as early as possible. The goals are trying to work up to at least 3 60-minute sessions per week at home. So the Myocycle is easy to use during short treatment sessions to maintain your clinical productivity. Session time is easily adjustable to adapt to any setting you're in, whether it's inpatient, outpatient, or a wellness setting. The Myocycle itself can be easily incorporated into your plan of care to achieve your patient goals. Patients with chronic conditions may need FES cycling for the rest of their lives, so they get those continued long-term health benefits, which is why FES cycles are available for home use. So as you're working with your patients, you want to be thinking from the beginning, from the evaluation, what is my discharge plan for this patient, and what equipment would be possible for them to utilize at home that's going to continue them to maintain their health as well as possible improvements in recovery. So right now, the 3 main types of FES cycles out there that are used in clinic settings as well as home, there's the Motomed VitaStim. Again, it's an FES cycle. It can be used on arms and legs. The stimulation is considered what we call add-on. So it's not technically integrated into the actual cycling pattern. Then there's also the RT300. That is, again, another FES cycle. They also can use arms and legs. The stimulation is integrated into the cycling pattern. It's a little bit more extensive education. You need more training from a clinical perspective from the company as well as a clinical rep. And it has a longer setup time. The Myocycle is a leg cycle, FES cycle at this time only. We do not have upper extremity FES cycling at this time. The stimulation is also integrated into the cycling pattern. The interface is very intuitive with increased user friendliness. It has an easier setup time, which is very adaptable in the clinic usage, and it's also very adaptable for the home use. When you have any kind of equipment like this in home, you want to make sure your patients and caregivers feel very comfortable with it, and it's very easy to use the interface and be able to do the setup without a lot of complication or a lot of education and instruction additionally. So here's another example again of the Myocycle, just to give you a good picture of this. Again, reiterating those FDA cleared indications of decreased atrophy, increased range of motion, increased circulation, and relaxation of spasms. That's a nice side view of Amanda. She's a T6 complete paraplegic. It gives you a nice look at what the body positioning should be in the cycle. So again, they can wheel up to the cycle, or they can be in a regular chair, they can be in a manual chair, or they can be in a power chair. So to get into a little bit of the principles of the Myocycle, which is different from the MotoMed and the RT300, really incorporates isokinetic cycling. So isokinetic cycling means they maintain a constant cadence. So the speed is set at 35 RPMs. So this allows the motor to either automatically assist a patient that's very deconditioned, that isn't producing the greatest muscle force yet, but through frequency and dosage will. It can also automatically resist active pedaling for those patients that are getting a very good response, producing that type of muscle activity we're looking for, and can actually provide progressive resistive exercise. So why did they pick 35 RPMs? So again, going back to all the research, most of the research done on FES cycling has been done between 35 and 50 RPMs. The best results in the slower cadence maximizes the muscle force at 35 RPMs. It's a constant speed, so it's also smooth and consistent. It enables a calibrated measurement to produce active power output is what we're looking for. So at 35 RPMs, you're going to produce the most peak muscle force throughout the revolution across those muscles, as it should be appropriate with the timing of if they were doing this functional activity on their own independently. So we're trying to produce that type of power that is going to produce the functional outcomes we're looking for. So another operating principle that is unique to the Myocycle is the stimulation pattern. The stimulation pattern is based on a patented algorithm where you take measurements of their leg, of their thigh, their lower leg, and the seat height. And what that does is it helps modulate the pulse width to maximize that torque transfer of muscle force, like I was just discussing in the previous slide. So by taking those measurements, you're ensuring that the actual stimulation is being patterned across the stimulation envelope to make sure you're getting the peak production of muscle force throughout each revolution, as it should be on each muscle group. So another unique point of the Myocycle is having this automatic spasm detection that you can place on a patient. So as you start the session, if the patient is very loose or does not have spasticity, this is allowing the motor to understand that they don't need to use a lot of force to propel their legs. So you'd pick the low. If they have moderate spasms or tightness, you could pick medium. If they have very tight legs or high spasticity or heavy legs, you could pick H. So that algorithm is already built into it. You don't have to do any calibration to allow the motor torque to help progress the patient throughout the session if they do have spasticity. Then throughout the entire session, you can do real-time adjustments. It shows you what is happening with the patient. You will see their symmetry. So if they are more hemiparetic, you can see that, and you can continue to cue them into using their affected leg more. You can adjust the stimulation on this page at any time. It'll tell you the distance, calories burned, and again, that power active output that we're looking for, and it's calculated in watts. So you can stop a session at any time throughout if anything arose, if you need to stop for any particular reason. So the level of stim is the maximum stimulation, which is the pulse width. And the pulse width goes anywhere from 0, which is no stimulation, up to 500 microseconds. So each level increases the pulse width by 25 microseconds. The muscle group intensity, which is the amplitude, which you can see on this screen, you can pick a low, medium, or high. The low is 50 milliamps, the medium is 90 milliamps, and the high is 120 milliamps. So you have different adjustability across the muscle groups as needed to get the appropriate response you're looking for. So clinical applications. In general, the Myocycle Pro is a skilled therapeutic modality, which is billable to insurance. So we usually recommend the CPT codes are neuroreeducation and therapeutic activities. So the neuroreeducation would be particularly, again, on your first time using it, you're truly assessing their motor response to the stim and determining what is the best therapeutic level for them to achieve great muscle contractions or the optimal muscle contractions. Once you're doing the actual activity, it's more of a therapeutic activity and should be billed accordingly. So FES cycling, the whole key to is to drive neuroplasticity to improve function and achieve goals in therapy. Early intervention combining FES cycling with traditional therapy promotes the best overall outcomes. The Myocycle Pro can be easily integrated into the plan of care. So you can have a shorter setup time, real-time adjustments with the FES throughout each session, easily adapts for a bilateral or unilateral use depending upon where the patient's impairments lie. And FES can be applied to multiple muscle groups as well. Overall considerations that you want to think about with FES cycling is cycle session time is dependent on available treatment time. Modifying the time to allow for easy integration. The goal with FES cycling is to produce maximum contractions to promote greater outcomes. The key point is driving that neuroplasticity. That is what you're doing whenever you use any form of FES, but especially with FES cycling, you're driving that neuroplasticity. So when you're looking at your spinal cord injury patients, they may need longer sessions due to driving that neuroplasticity, especially if they're a complete injury with no volitional movement at all. This allows for them to get the increased effects of reducing further atrophy and also reducing spasticity. And it also leads to muscle conditioning and overall improvement in health. So MS patients are a little bit different. So MS patients, you need to take into consideration assessing their sensation. And the biggest emphasis is being conservative with duration of cycling, because the key consideration with MS patients is avoiding them achieving central fatigue, which is what we're always concerned about whenever we're doing any kind of rehab program with anybody with MS. And then your stroke and brain injury, again, the key consideration there is most of these people will have sensation, so you need to assess their sensation, their tolerance for the stimulation. And again, they might only need a unilateral setup, and you can be a little bit more creative in which muscle groups you want to apply it to, but this also allows you to integrate some of the core and some of the lower leg options as well. So treatment outcomes that you should be looking for in each setting. So in the inpatient goals would be decreasing hypotension for those patients, increasing their sitting tolerance, decreasing spasticity, again, increasing range of motion. You want to decrease any potential edema due to the fact they're not producing muscle activity, and maintaining the range of motion. So you're also increasing their overall endurance for activity, period. That's what you're looking for in inpatient. You're getting them started and you're still trying to drive those different outcomes to help them improve and get them ready for discharge. Once they're in the outpatient setting, you're looking at, again, continuing those benefits, but you're going to have a greater increase on their endurance, decreasing spasticity further, which leads to improvements in posture, muscle conditioning, range of motion and strength. You can increase sitting and standing balance, improvements in transfers, which is, can be bed mobility, supine to sit, rolling, decreasing pressure stores, preventing decreased bone density, and increased potential improvements in gait if they are ambulatory. So any of those things you can make changes to and can have carryover effects, which are going to carry over into all their functional ADLs that they're performing every day. So therapy treatments ideally begin with using the cycle first in a treatment session. Then you want to continue with the rest of their treatment. This way you get to truly assess those carryover effects and changes in function. This also allows the patient to feel those benefits too, and cueing them into being able to potentially, if they are ambulatory, they can advance their leg easier, they're not having foot drop, their balance is better, their posture is better, things like that. It could also be as simple as wheelchair propulsion improves with those patients that are working on that. Their increased activity in general for all of their exercise and their therapy session improves as well. And you can see improvements in decreasing spasticity as well as improving muscle bulk and muscle conditioning. In a wellness setting, you're looking at continuing to maintain the muscle activity you've already produced, helping them maintain their physical conditioning, and just continuing to prevent those secondary complications. And again, in all three settings, looking at your discharge planning for this patient, is this someone that would benefit from this long term? And I want to keep the gap from discharge to potentially getting it as short as possible. So how do I continue to help this patient through the continuum of care? So here's a video of a home user we have that has the Myocycle. He is a T8 complete paraplegic. What I like about this video, when I was telling you about producing muscle contractions, as you can see, by putting the electrodes on each muscle group, you're really trying to provide true muscle activity. The greater the contraction, the greater the effects to help improve them across functional outcomes. It also shows you a very good idea of what positioning is like and where they should be in conjunction, centered on the cycle, as well as maintaining a slight knee bend throughout the actual session so that you're not putting undue increased force on their knees. So continuity of care. So best overall outcomes result from the use of this across the continuum of care. So inpatient to outpatient to home. And remembering, FES cycling is a skilled intervention. It provides functional activity for those neurologically impaired patients. Home users experience continued long-term benefits, which lead to improved quality of life with improved physical health, decreased rehospitalizations, which, as we know, is becoming more and more predominant in our field, making sure that our patients aren't being readmitted, and also reducing all secondary complications that could potentially occur due to decreased physical activity. And here are some references just for you to look up if you'd like to. There is just an abundance of studies, case studies, pilot studies, all on FES cycling used. There's a plethora of it on spinal cord in particular. There's more coming out on CVAs and brain injury, and there's some more coming out on MS patients. So again, these are a few I wanted to highlight for you in regards to spasticity, bone density, prevention of atrophy and building muscle, increasing strength across the board over different diagnoses. Well, thank you. I appreciate that. I hope that provided some background and some good information on how this can be utilized more appropriately in the clinical setting, and also opens up the door to those patients that should be having this potentially for home and that will benefit and help them have a healthier, better quality of life. Thanks, Kathleen.
Thanks, Judy, for a really great talk and a lot of really great pearls from your clinical experience. It's really amazing to see how FES cycling technology can evolve, across that plan of care for a wide variety of patients undergoing neurorehabilitation. I just wanted to ask you a few follow-up questions, and I think the first one is really related to clinical populations. I know when I first started learning about FES cycling, I was very aware of the applications for spinal cord injury and spinal cord injured populations, but you also highlighted, a number of other applications in CVA and MS and TBI. And you talked a little bit about how those treatment goals might change, particularly for those different indications. But are there any other things that you want to add in terms of how that session might be structured differently for some of these different populations?
Yeah, Kathleen, I think the biggest thing with that is, as a therapist, when you do your evaluation, what are their impairments? What are your goals you're trying to achieve? So FES cycling should be another modality you're utilizing to achieve those goals. So if right now the patient is completely wheelchair bound, you're doing more of that conditioning, endurance training, cardiovascular. You want to help prevent further bone loss or bone density issues. You want to help prevent pressure sores, and you're trying to drive circulation. If those patients, though, are starting to have increased ability to perform transfers, they're starting to get some recovery, range of motion, strength, potential standing, gait, then you're literally looking at what is that FES doing to drive those things? How am I priming their system? How am I driving that neuroplasticity? I'm bringing back muscle memory to those patients, and they get to feel that. Even if they have decreased sensation, it helps them attune to that and helps them remember, and it recreates that signal to the brain, which helps that patient realize this is the way I should be using this leg now or this arm as I try to do my ADLs. And those are the things you're cueing them. So that's why it's really important to use it first in the session, so that they get that reinforcement, they get that reactivation, you prime their system, and then you keep encouraging them. Remember how that felt when you were trying to push on the cycle? That's what I want you to do now when you go to stand. This is what I want you to do now when you go to transfer. When you were cycling, remember, I want you to pick your foot up. I want you to come down on your heel. All those things are the things you're going to keep reinforcing, just like you would with any other modality that you're using to achieve those goals.
That's great. And kind of speaking of priming the system, that sort of leads me into my next question, because I thought that was a really interesting point you brought up about using it at the beginning of the session to sort of, wake everything up and really get them ready for the rest of their session. Can you talk about, and obviously that would be more for patients with some degree of volitional control, I would assume.
Mm-hmm. Mm-hmm.
So can you expand a little bit more on, what that session plan might look like? How much time would you spend on different activities, or what are some of those verbal cues, as you just mentioned, that can be particularly helpful in some of these patients?
Yeah, so again, some of those patients, as we discussed, it may be more hemiparetic or are getting returned back. So with those patients in particular, if you achieve those good muscle contractions that I showed you in the video, it's all about producing the best contractions. So when you're producing that type of contraction, you don't have to have a lengthy session. Those are those patients you can really get that 10 or 15-minute session on. So you're priming their system, you're doing muscle memory through the stim, and then you're utilizing that as you carry over into the rest of your treatment plan. So that's what I mean by priming the system, more so than if you're a complete injury or unfortunately, if you're a severe head injury, stroke, or your MS has gotten to the point where you're completely wheelchair bound, that's a little different. You're working more on endurance and those overall effects that you're trying to do by decreasing, helping to decrease further bone density, making sure they don't have pressure sores, having greater effect on keeping them more cardiovascular fitness. But those patients that have some burgeoning recovery and are more hemiparetic potentially, you can do anything with the stim. That's the point. So you really want to cater it toward your goals, and that allows you to figure out your session time so you can use it the most efficient way so you can get everything you need done in an efficient time manner.
Makes sense. And it always comes back to what are the functional limitations and what are the goals of the individual patient. I think that's come up in almost every episode that we've done so far.
Yep, because no two patients are the same regardless, and each one gets different benefits too. And again, sensation plays a factor for those patients, and cognition. Cognition is one of the key elements, with working with these patients. You have to take into consideration all those things and how you cater that to meet that patient's goals as well.
Exactly. And then I guess speaking of, patient goals, I think in terms of longer term goals, you talked about, that many patients can benefit from long-term, home exposure and home use of FES cycling,
right.
As a long-term therapeutic intervention. And I know sometimes it can be a challenge for therapists to really evaluate, who are the patients that are going to do well with this at home, or who are going to be the best candidates for a personal FES cycle. So I'm wondering if you could comment on any insights that you have from your experience about what you look for in terms of who you think would make a good potential home candidate.
Great. That's a great question. And I think it goes back to, and when I'm working with clinicians in general, the first question I ask is, well, why did you decide to use this in your treatment plan to begin with? What were the benefits you were trying to derive? And then how did you educate your patient on why you were using it? So everything we all do as therapists every day is about education. How do we educate our patients as to why we're doing a particular treatment, how it can potentially affect them? So that's what you're looking at. How much does this patient understand? Do they understand the benefits? Do they understand why I'm using this with them? And if they do, that's the key. The more they understand the benefits and why it's going to help them, the more eager they're going to be compliant. Because I know one of the questions we always think about as a therapist when we provide any home program of any kind or any recommendation for whether it's a brace, whether it's an assistive device, wheelchairs, whatnot, how compliant is the patient going to be with it? And again, I think that goes back to education. But if they really understand what this can do for them, they should be more apt to want to use it. And that's the key thing we have to find out. The other thing is, technically, the Myocycle is truly designed to be an independent setup. In the short clip of the video, most paraplegics can actually do their own independent setup, from electrodes to positioning to everything. So one of the things you have to consider is, what is their level of injury? What is their functional limitations? And if they do need support, do they have that support at home? Do they have caregivers, family members, someone that's going to be there that's going to help to assist them with the program as needed? So like with anything, when we're ordering any equipment for patients, we're always thinking about all those things. So compliance, if they need assistance, can they be independent? Then I think the other thing that I didn't really touch upon, but I should have, would have been MYOLYN itself. We do have a Myo portal that tracks everybody's sessions. We do offer ongoing clinical support, which is my role. So when a home user is home with the cycle, I work with them. I do FaceTime chats. I do emails. I can look at all their sessions and continue to provide them support to optimize their program, so to make sure they're getting what they want out of it. So that's the other thing. How do we ensure compliance? We have to give support. Without support, it's harder for people to maintain their compliance with things. The other thing to think about too, especially in the outpatient setting, a lot of these people continue to go back for short periods of time for outpatient therapy. If they're using a cycle at home, that allows them to work on other goals when they go back to therapy, instead of having to take that extra 20, 30 minutes out of their treatment program to do this. And again, the greater the usage, the frequency and dosage, the more effect it has. So only doing it once a week is not nearly as effective if they can do it at home 3 to 5 times a week. So again, you're looking at the whole spectrum of the patient. You're looking at what their home situation is, what their understanding is, the potential for compliance, and then the assistance they may need. And you always want to look at what companies offer technical support, clinical support for those patients for the longevity of how long they own the device.
Great points. And then just lastly, to kind of wrap up, you shared us a lot of resources with us in terms of references, and I'm going to include all of those references in the video description below. But for any of our viewers who would like to learn more about FES cycling, specifically for neurorehabilitation, are there any additional resources that you might recommend to help them kind of learn a bit more?
Again, there's so many studies out there. I know in particular on the MYOLYN website, there is, you can go onto the website and you can get a list of the clinical benefits of FES cycling, which will list a majority of these studies. But you can go into almost any neurological journal of any kind and just start to reference FES cycling. And there's multiple different avenues for looking at that. But if you wanted to get a quick reference guide, there is that clinical benefits of FES cycling that MYOLYN does provide on their website.
Okay, great. And we actually have that on the ReWalk website as well. So I'll include both links to that in the video description below.
Great.
All right. Well, thanks so much for a great talk, Judy, and thanks again for your time.
Thank you very much for having me. I really appreciate the opportunity to get more information and education out there about FES cycling in clinic and home. Thank you.
And to our viewers, we hope that you've been finding these talks interesting and educational. So don't forget to reach out in the comments section with some of your tips and recommendations for using FES cycling within your own clinical practice. And also make sure to like and subscribe to this video using the buttons below. And you can also use the comments section to suggest any future talks or speakers that you would like to see from this series. We hope you tune in with us again next episode, and take care, everyone.
Thank you.